All right, very good. So welcome, everybody. Thank you for joining today on Wonderful Wednesday and part two. Sorry about that. Part two of unstable tachydysrhythmia. So it doesn't matter if you attended last week or not. That's okay. We're just going to follow up on a couple of things that we talked about with unstable tachycardia. And how do we know what we're doing? How do we actually make a good diagnosis and a good suggestion for intervention? So always, so sorry, I don't know what's happening here. Okay, so always really important when we see a rapid rhythm. Of course, our first question is it narrow or is it wide? And always reminding ourselves that if you're tachycardic and wide, there are a couple of things we want to look at. Is this possibly VT? Well, in that case, it's okay. Cardiovert, give amiodarone. If it's SVT with aberrant conduction due to bundle branch block, it's okay. You can give amiodarone, you can cardiovert. But if it's SVT with aberrant conduction due to accessory pathways, and we talked a little bit about that last week, particularly Wolff-Parkinson-White syndrome, which are accessory pathways that bypass the AV node, you do not want to give these patients agents like you're looking at as SVT. You don't want to give them adenosine. You don't want to give calcium channel antagonists. You don't really want to give amiodarone. What you really need to do with these patients is pronestyl, albuterol, or cardioversion. So the answer for any broad complex tachydysrhythmia is if the patient is unstable. It's great if you can diagnose them first, but cardioversion would be first, not necessarily pharmacologic management. And we really have to be careful when we're talking about wide QRS tachycardias that might be related to accessory pathways. Now, that's not a huge percent of our patients, but it does occur. This is really important because AV nodal blockers, so beta blockers, calcium channel antagonists, adenosine, those agents can cause a very precipitous instability and movement towards ventricular tachycardia and those wide QRS tachydysrhythms. So when we talk about wide QRS tachydysrhythms, we really talk about a couple of different mechanisms that can occur. First of all, we know that you have an increased automaticity in an ectopic site. It might also be in a normal site, but typically it's ectopic. And typically what you see first are abnormal depolarizations, and then runs of abnormal depolarizations, and then a tachycardia presentation. And in this case, we talk about atrial tachycardia, or we talk about ventricular tachycardia, remembering always that prodrome is the initial appearance of a premature depolarization, and then a constellation, 3 or 4 or more in a row. And then that's prodromal to an overall rhythm that's been controlled by an abnormal foci, which may present in what we call a circle reentry. And so it gives us a very similar presentation every single time. Now, we're going to add into that the ability to re-enter. So there is re-entry of electrical activation back up through a normal pathway. That typically does not cause significant problems, but you could see that in atrial tachycardia and atrial flutter. That's really about the atria and not the ventricle. But when we see reentry through an accessory pathway, the accessory pathway bypasses the AV junction. So what happens is you get into a circle reentry, you fire, and perhaps you go down the AV junction, then back up the accessory path and down the AV junction and back up the accessory path. That's commonly what we see in WPW. Now, most of these rhythms are actually, or abnormalities, are actually triggered by ectopic beats. So our first concern is bedside providers. So when we're looking at patients, remember, we're going to look and see, are you regular or irregular? And are you narrow or wide in terms of your QRS? So very important to say, okay, regular and narrow could be sinus tachycardia, could be AV nodal tachycardia or reentry tachycardia, could just be AV reentry tachycardia, but not necessarily the node. It could be atrial flutter, it could be AFib with a variable block, it could be multifocal atrial tachycardia, or atrial fib. So really important. If you have a wide QRS, and that's the one that's really more worrisome because it's a little harder for us to diagnose, a little bit harder for us to say, I'm going to treat it this way or that way. And in general, we just say, give amiodarone. But remember, amiodarone can be an issue for our patients if they are having AV nodal reentry tachycardia. So again, if we look at wide and regular, we talk about VTach, we talk about AV reentry tachycardia, but only in one direction. So that one direction is not pro, going from atria to ventricle, but it's from ventricle back up to atria. That's called antidromic AVRT. Narrow complex tachycardia may also have aberrancy. So we want to be sure that when we're looking at strips or 12 lead EKGs, that we have some basic capability to differentiate bundle branch blocks. So we can really look at narrow, or when we say narrow complex tachycardia, but now it's got aberrancy. So it's no longer a narrow complex tachycardia. It's a wide tachycardia, but it is absolutely regular. Now, the thing to remember about VT is regular. VT is regular. So one of the things we're always going to look at when we look at a strip quickly is we're going to say, is it regular or irregular? Because VT is almost always regular, unless it's coming from more than one ectopic source. So if it's polymorphic VT, it tends to be quite irregular. And if you have AFib or aflutter with aberrant conduction, that could also be irregular. So again, the first thing we do when we look at a strip or we look at an EKG, is the QRS narrow? That means less than 0.11. Or is it wide? That means typically greater than 0.12. Is it regular or irregular? So you really have to have a good eye when you're looking at the EKG to make those decisions. So we're going to take a quick look at this. This one is pretty simple, right? It's regular, it's narrow, it's really fast. And we're not sure that we can see any P waves. There may be P waves, they may be buried in the T, but we have a narrow QRS and nothing seems wider than 0.11, and it's absolutely regular. So because it's a narrow QRS, because it's absolutely regular, we're going to put that under that first classification of narrow and regular, but we still don't know the answer. We don't know, is this atrial tachycardia, or is this an AV nodal reentry? So that's going to be the first thing that we're going to need to work out. And one of the best ways we can do that is that we want to slow that rate down. And we're going to ask the patient perhaps to Valsalva, to bear down, like they're having a bowel movement. We're not asking them to do that so they're going to convert their rhythm. But what we want to actually see is, are we able to slow the rhythm down enough for us to actually see what's occurring? Another really great way for you at the bedside to actually look at this is go to your sweep speed on your bedside monitor or your 12-lead EKG and put it in 50 sweep speed. Now, normally you're monitoring 25 sweep speed. That's the speed of the paper. When you go to 50, you're going to actually be able to prolong the time between the R to R, and you're going to be able to find out, do we have a flutter wave? Do we have a reentry, an antidromic, which means an inverted P wave? Is the P wave just buried in the T wave? And when I spread it out, do I find it? Such a great way to help diagnose an abnormal rhythm. Now, we're going to be worried about this because it's very, very, very tachycardic, right? We're about 200, somewhere almost close to 300, really, really fast. I'm just looking at it really quickly because they're knocking on my door. Get out of this room. So really, really important that we really just give a quick look. We look at the rate. We look at that rate and the regularity and say, if it's 200 or greater, that's probably not the ventricles. It's regular, probably not the ventricles. And that's really important because VTach typically is somewhere between 150, sometimes up to 210. When it's from a unifocus, it'll be much more rapid when it's multiple foci, but when it's multiple foci, it won't be regular. So we use that regular, irregular, and wide and narrow. That gives us really great information. Really important to remember, the most common dysrhythmia is atrial fibrillation. Everybody here knows about atrial fib. You don't need me to tell you about atrial fib. But what I want to talk about with atrial fib is that your atria is firing at a rate between 300 and 500. And a fair percent of that, particularly if you have an accessory pathway, so don't forget that you're going to conduct a fair percent of that. Now, your normal AV junction is going to protect you from that fib depolarization communicating down to the ventricle. But if you have an accessory path, you have no protection. Your normal AV junction has slow channels and fast channels, and that's the way it controls the conduction of the impulse from atria to ventricle, but your accessory pathways are typically just fast channels. And so they are going to conduct really rapidly. They don't have much delay time, and that's what's really important. So I can have a fib and have AV reentry, atrioventricular reentry or ventricular atrial reentry, and I can have a heart rate of 280. It may be wide, but it typically is still not regular because it's conduction of the fib wave. So it's wide, but it may not be regular. And that's something we can see pretty clearly in atrial fib. Now with atrial tachycardia, and when we think about atrial fib and atrial tachycardia and their correlation to each other, I just think this is a great visual. I wouldn't worry too much about what's down here. But when you see up here in atrial tachycardia, you just have impulse formation in the atria. Whereas when you have atrial fibrillation, you have multiple sites of formation. And then when you look at atrial flutter, this is such a lovely visualization of what I'm calling a circle reentry, or actually circus reentry, is that what you're seeing is you have one impulse that just travels in circles. And that's why the flutter wave looks absolutely reproducible. Flutter wave 1 to flutter wave 48 to flutter wave 3072 is absolutely reproducible, because unlike AFib, which is multifocal, this is usually a unifocal design that is being conducted in a circle. And then occasionally or rapidly, it's being conducted down into the ventricles. Here, what you're seeing is a nodal reentry tachycardia. So if I have a tachycardic rate, or I have a normal heart rate and it's transitioned down here, it gets communicated back up into the atria, and you actually have what we call a circle reentry through the AV node, through the accessory path, and that is typically uncontrolled in terms of rate. So this is really important, not because I'm expecting everybody here is going to appreciate and say, oh, doctor, this is a multifocal atrial tach with reentry. That's not really important. What's really important is to know that when you treat a patient and things get worse, you treated the wrong thing. And not to give more of the same. You treated the patient, things got worse, you weren't treating the right thing. And that's what's really important to us, is that we may not be able to diagnose you initially. We always want a cardiologist involved, particularly an electrophysiologist. But when we've done therapeutic intervention, so let's say you had a rapid, very rapid atrial tachycardia or atrial flutter with a junctional, with an AV nodal reentry. So it can be either by an accessory path or through the AV node itself. And the patient's heart rate is really rapid. It's somewhat wide. And we said, first thing, let's give some amiodarone. We give amiodarone, or we gave adenosine because we think it's supraventricular tachycardia apparently conducted. We gave adenosine, patient deteriorates into VF. Okay, well, all right, let's get you out of VF. And then let's say we're not going to do that again, right? We're not going to do that again, not because the drug was bad, but it wasn't the right therapy for that patient. And that's why it's so important for us to differentiate these tachydysrhythmias. Okay, so atrial flutter, look at that reentry circuit. It's always a reentry circuit, usually held over a large area of the atrium, more common to occur in the right atrium than the left atrium. And the rate is usually greater than 240, can go up to about 400. Unlike fib, which goes up to 500, flutter rate can go up to about 400. Really, really important to remember with atrial flutter, one of our concerns is that you have significant and profound sympathetic stimulation. But if you also have an accessory pathway, these patients should not get any kind of junctional block. They shouldn't get beta block. They shouldn't get calcium channel antagonists. And again, you may not be able to make that diagnosis immediately. You've given a beta blocker, you've given a calcium channel antagonist, and the patient gets worse. So that's really, really important. Remember, the purpose of that AV junction is to protect your patient from those atrial rhythms being conducted to the ventricle. But here's the problem. When you have an accessory pathway, when you protect the junction, you make the accessory pathway more in charge. And that's why the patient deteriorates when we've used AV nodal blocking agents, because AV nodal block works on the AV junction. But remember, the accessory path is a fast channel. So when we have accessory pathway disorders, we're going to do something that affects fast channel more. And it's usually going to be agents we don't use normally, like pronestal, like obutylide, which are really sodium channel antagonists or sodium plus potassium channel antagonists. We don't normally use those because they're quite pro-arrhythmic. You have to have a cardiologist involved here. So, by the way, I love the fact that when you work in trauma, when you work in the ECC, you're really strong in your perception of how you understand EKGs and cardiology. But I don't want a cardiologist opening up my abdomen, and I don't want a trauma surgeon managing my dysrhythmia. So I really need cardiology to come. And I'm not necessarily pro-cardiology any more than I am pro-trauma surgeons. I just think that they have a high level of expertise, and maybe they spent a year in critical care fellowship. That doesn't make them an electrophysiologist. So we just have to be aware when it's time to get a cardiology referral. And we'd like to do it before the patient deteriorates, if at all possible, when we have abnormal rhythms. Okay, so I showed this picture last week. This is a flutter with a 3-to-1 block, and of course, one of the best diagnostic tools. Turn the EKG upside down, the flutter waves look exactly the same. And this is pretty obvious because you have three flutter waves to 1 QRS. So that's a pretty obvious visual. But I want to also really focus on what it is we call SVT. So we're going to call a flutter SVT when you have rapid conduction. We're going to call AV nodal reentry SVT, and that's a nodal reentry pathway, and an AV reentry, which is an accessory pathway. All of those things, and junctional tachycardia as well, if we can't differentiate them, we put them into a big bucket called SVT, okay? But very important to remember that almost all SVT, 60%, is reentry within the AV node, and in 20%, it's reentry involving a bypass tract, which means I have to change my mind about what I want to do in SVT. So last week, we talked a lot about giving adenosine 6-12-12. You can give more if your cardiologist asks you to, but the thing is, if patients don't respond to adenosine, or if they get worse, that's not the agent. So why continue? Once you've given 6-12-12, you need to move on to something else. If you give it to persons who have bypass tracts, and sometimes to persons who have AV nodal reentry, which remember 60% of SVT does, those patients are not going to respond to adenosine, and they may actually get worse. So really important for us to remember. So first and foremost, regular, narrow, complex tachycardia. This is what the American Heart Association recommends is number one, attempt vagal maneuvers. Now, one of those maneuvers is massaging the carotid bodies. We don't do that as bedside nurses. You do not ever do that. You can cause asystole, and they may not be able to resuscitate from that, at least without a code. So don't do that. But you can ask patients to have a cough. You can ask them to bear down. Those are vagal maneuvers that we apply. Only cardiology should do carotid sinus massage. If you have time, get an EKG. You can try adenosine, remember, but adenosine may cause that to deteriorate. But that's what the American Heart Association and in your ACLS guides, that's what they're going to tell you with narrow, complex tachycardia. It's probably SVT. It is SVT, right? If you can't determine what site above the ventricles is originating the firing, it's always SVT. SVT isn't a diagnostic. It's a big global catch-all phrase, because I don't know if it's flutter, I don't know if it's AV nodal reentry, I don't know if it's AV reentry tachycardia, I don't know if it's junctional tachycardia, because it's too fast, I can't figure out. Again, I want to make sure you apply the 50 sweep speed rule. You've got a 12 lead EKG, ask them to run it in 50 sweep speed. You've got an EKG on your monitor, put it in 50 sweep speed. Now, people are going to get very upset because now they're going to think the patient is bradycardic. But what you're doing is slowing down the visualization so you can look at the point of origin in the atria. Is it a normal P wave? Does it occur regularly? Does it have normal morphology? What else is occurring? So remember the importance of your P waves here when you're looking at wide QRS tachycardias, and we talked a little about that last week. Okay, AV nodal reentry tachycardia. Remember that in your AV junction, you can have fast and slow fibers, fast channel, slow channel. Fast channels typically sodium channel, and slow channels are particularly calcium channel. But in your AV node, you can have a prevalence of your fast channels, and of course, you can also have a bypass tract. Now, remember, as you move antegrade, you're moving in from atria to ventricle, and as you move retrograde, you usually do that through a bypass tract. That's also called orthodromic narrow complex tachycardia. So if it's antidromic, that means that you have a wide complex tachycardia that looks like VT. But remember, if you treat this like it's VT, other than cardioversion, if you treat this like it's VT, you may cause very significant and profound deterioration. So I love this little visual that just shows you slow channels and fast channels, right? And so you can actually have more access through the fast channel without some of the slowing. That's one of the ways that you have it. And that you can just be communicating down your slow channels, then activate your fast channels, and then that goes back up into the atria and then comes back down again. And you can have slow channels, again, that also are activating down to the ventricle and activating your fast channels. But this one, you're activating your fast channel and depolarizing the atria again. Here, you're really just depolarizing the ventricle before the AV junction becomes depolarized itself. Okay. Want to talk about WPW? I think that's probably going to be as far as we're going to be able to get today. And then our next time, we're going to really talk about VTAC and polymorphic VTAC, and by the way, torsade de pointe. So I really do think it's important for us to at least have a basic understanding of WPW. It's the most common of accessory pathways. You can have one on the right, you can have one on the left. It's not that many patients, 1 in 1,000, but those are only the patients that have reported WPW. So there may be many more patients who have it, but they just at home, they notice that they have short bursts of rapid rate. Sometimes we'll say, oh, we're going to evaluate you for mitral valve prolapse, but you don't have that. We're going to do an EP study because you may have an accessory pathway. Now, accessory pathways typically will conduct from atria to ventricle and from ventricle to atria, and that makes them very, very hard to control. And those tachyarrhythmias, of course, are called AV reentry tachycardia. Now, these bypass pathways, once you have an ectopic formation that either is antegrade or in the forward direction, in either case, if you have an ectopic depolarization, you can take complete control. Oh, hang on 1 second. I think that's probably my, they're calling me to say, get out of this room. Sorry, I was speaking at a conference in Louisville and I'm in my hotel room and I was supposed to leave at 4. So, okay. So really, really important. And that gave you a minute to digest what I'm saying. So here are these accessory pathways that don't have any of the control the AV junction does, right? The AV junction has that combination of fast and slow depolarization. So when I have a patient who is being controlled through their bypass pathway, there's no slowing. So anything ectopic that arises in the atria or the ventricle will be either in the antegrade or retrograde conduction, and that means it gets completely out of control. And the things that you normally are going to use to control the AV junction, beta block, calcium channel block, and adenosine, can be very harmful because they're not going to affect that bypass tract. So just really remembering that the bypass tract tends to be more sodium channel dependent. Here's a time, I don't advocate for this very often, but here's a time where we want to use a sodium channel blocker. So for those of us who've been around in cardiology for a while or been around critical care for a while, we'll remember that really with fast channel dysrhythmias, which typically are VTAC, we would use lidocaine, we would use pronesil, we would use quinidine. Those are 3 classifications of sodium channel antagonists. We really don't like those. We don't use them much anymore because they're very pro-arrhythmic. But when you have an accessory pathway, you are going to use sodium channel antagonists. And the one that we use the most will be pronesil, which is relatively easy to get. Butylide is a little bit harder to get. Both of them require cardiology. They both require cardiology. You can't just be a cowboy junkie and jump off the bridge and say, I think we need pronesil. You've got to have cardiology and preferably an electrophysiologist. Now, here's the problem. When you have AFib or a flutter and you have an accessory path, you're going to have really profound and significant deterioration. And it's going to be very hard for you to control. And again, you might be thinking, well, this looks like SVT. I'm going to give adenosine. I'm going to give a beta blocker. I'm going to give a calcium channel blocker. You might not be thinking anything. You're just doing. Somebody ordered it. You gave it. Your patient gets worse. Got to step back from that and say, hey, I think maybe we didn't make a good decision. If the patient is unstable, you're going to cardiovert them. That may or may not help with WPW. And that's, of course, the big problem. Okay, so if we just take a look here, this is just a nice visualization. It's very primitive, looking at normal conduction. But when you have this accessory path, what actually happens is you lose your PR junction, your PR segment, and the P wave slopes right up into the Q wave. That's called a delta wave. You have no delay time, right? Because you've lost that delay time because you're not really depolarizing through the AV junction. So what you see is something very important that's called a delta wave. It can be going from the P wave up into the R wave, or if your patient's primary depolarization is downward, that might be an S wave or a Q wave. It may go downward, but it's a delta wave, and it makes that QRS look quite wide, but it's really definable because you really can't see a P wave. P wave merges into the QRS. And typically your ST and your T wave are going to go in opposite directions. That's called discordant. Because this is an abnormal depolarization, you're going to see abnormal repolarization. Okay. This is a patient. So I look at this first. I say, is this regular or irregular? It's irregular. So I don't think it's VTAC. All the complexes look the same, but it's irregular. My patient might be pretty unstable. And again, the first thing I might try would be cardioversion. Okay. But the other thing is that when I have these slower beats here, and really I only have it in these two, I can see that I have this tad bit, or I have 3 of a delta wave. Okay. Now I'm going to tell you, if I looked at this strip, and I'm no electrophysiologist, I probably would not have looked at that strip and said, this is WPW. I know that because later, when we looked at the basic EKG, we saw that the patient actually had a communication as their heart rate was slowing down, had that communication again of the P wave going up into the QRS. Here, if I have time, if I'm not worried that my patient is completely decompensating, and they might be because the rate is so fast, I'm again going to put you on a 50 sweep speed, because I'm going to look for whether or not you have a P wave and how that P wave relates to the QRS. That is one of your best diagnostic tools. Nobody uses it, but it's such a great tool and such a great way for you to look at your patient. Okay, now we're going to take a look at this one. Okay, you look at that and you say, oh my God, this looks terrible. Well, your patient has RV hypertrophy, first of all, so that makes everything look abnormal. Patient also has a right bundle branch block. That makes it look really abnormal. And your patient has their P wave going up into their QRS. Your patient has WPW, and he also has a right bundle branch block picture. Okay. This is a 5-year-old, so thank God we're not going to see that patient. This is pretty common. When you see young children who have WPW, their heart rates can be faster than 220, and it's terrifying when you look at those patients. Here's a 30-year-old with WPW, and this is their first EKG. I've got a second EKG. And when we look at this, again, it's pretty hard for me to assure about their P waves. This is actually their T wave. That's not their P wave. And again, much easier to diagnose if I change my rhythm strip to 50 millimeters a second, broaden it out, try to look for that P wave. Okay, now this patient has ST segment abnormalities, but those are not from a non-STEMI. Those are repolarization abnormalities because they have WPW. So if this patient came to the emergency department, they said they were having some chest discomfort, you would think right away, this is a non-STEMI. Look, I've got ST segment depression, V4, 5, and 6. I've got it in 1, not in AVL, but I've got it 1, 2, and AVF. Oh my God. And I have ST segment elevation AVR. Oh my God, the patient's infarcting their whole heart, which is always possible with a CTO, chronic total obstruction, but that usually presents as a STEMI. This is presenting as a non-STEMI. It's pretty unusual to see ST segment depression in all those sleeves. So we might call for a cardiology. We might say, we're not sure about the diagnosis. I need a cardiology consult. If the patient is stable enough to wait for a cardiology consult, cardiology will come, they'll look at them, they'll call the electrophysiologist, and they're going to come to the conclusion that patient has WPW. Okay. So she was pretty unstable, but remember, we don't want to block the node. So we're not going to use adenosine. We're not going to use calcium channel antagonists. We're not going to use a beta blocker, which is what we'd normally do with SVT or in terms of how we're going to control those patients. And sometimes we use amiodarone. Typically in SVT, amiodarone doesn't work that well, but that's okay. We're going to ask the patient to bear down with a Valsalva. We're going to call cardiology. We're going to consider pronestal. We're going to consider amiodarone. Once we get you a little bit under control, I'm going to use amiodarone later, though. I'm going to use pronestal or ibutylide if I can, and amiodarone later. And then once that's under control, I'm going to consider that the patient needs to have an ablation or they need to have surgery. So most commonly, we're going to do an ablation. We send them off to the EP lab, and the electrophysiologist burns or basically murders the accessory pathway so that the patient now will only conduct through the AV junction and not through that accessory pathway. And WPW is not the only one. There's a lot of different accessory pathways, all named for the physicians who discover them. So like Lamgonaglavine, the bundle of Kent, there's a lot of different accessory pathways, but WPW is the one that you see most frequently, which is why I'm spending time on that. Okay, look at this patient. This is WPW with atrial flutter. Or atrial fib, I'm sorry. So I look at this patient and I say, very first thing, this is really terrifying. But by the way, it's a wide QRS, but it's irregular. It's a wide QRS and it's irregular, and it's all in the same focus. If I'm looking for the same focus, what that basically is telling me is that depolarization is pointing in the same direction. So I see on this nice rhythm strip that it's all pointing upwards. It's the same focus and it's quite irregular. So it's a wide QRS and it's irregular. So if it's same focus, wide QRS and irregular, most likely is not ventricular tachycardia. And we know already that this is a patient with WPW who has atrial fibrillation. So again, kind of the thing you're thinking about is, well, he's got atrial fib, so I'm going to use a calcium channel antagonist. I might use a beta blocker to try to control his rhythm. But because he also has an accessory pathway, that will not be the choice. Now, I want to remind you that it's always important to differentiate bundle branch blocks when we're talking about wide QRS tachycardias and really looking for whether it's a right bundle or a left bundle branch block. I want to remind you also that you may not have pathology to your bundles, but when the firing rate above the ventricle is high, so typically higher 150 to 180, the right bundle doesn't have time to repolarize, so your right bundle becomes effectively blocked. It does not depolarize effectively. That's quite important for us to know, because we can look at this patient here. So maybe when you looked at this EKG, you might have said, oh, that looks like VTach. Guy has palpitations. He has a fairly regular wide complex tachycardia. So the belief is this might be VTach. Maybe it's something else. Don't really know, but I'm going to synchronize cardiovert him, which is what we always should do, always. With VTach, it should always be synchronized cardioversion. So we turn on our synchronization, but what we have to be aware of is that the synchronization is saying to fire here. It's recognizing this is the R wave, but that's actually R on T. So that's really, really important. If you look at your synchronization pattern, so you're looking at this patient, he has palpitations, he's feeling quite badly, but it's not completely unstable. Take a minute, take a breath, look at where you're actually going to fire. And you can see right here that the advice is to fire right here because that's what it's seen as the QRS, but you are actually on the T wave. So it does get depolarized right there on the T wave. And of course, what happens to the patient? The patient goes into basically into a polymorphic VT. Can't say for certain that it's TDP because you have some criteria, TDP meaning torsade de pointe. You've got some criteria that have to be matched for us to say that it's TDP. So here's the thing. Always deliver your shocking and synchronization. Make sure you're not shocking on the T wave, because when we shocked on the T wave, patient went into a polymorphic VFib, polymorphic VTach, polymorphic VFib. Don't ever mess with the T wave. If you think you have a T wave, don't mess with it. just leave the T wave alone. That's a time when your ventricles are going to be very susceptible to an electrical depolarization. So always reminding ourselves that we want to avoid synchronization that fires during the T wave. The T wave is a period of time that we actually say is relatively refractory. Okay. And relatively refractory, sorry, that's the downside of the cell depolarization. When gathered together, that's the downside of the T wave. So your pole is almost back to normal, going from a more positive to a more negative pole, but a strong signal can cause complete and utter electrical chaos, just like what you just saw here. So always really important to remind yourself that if possible, you always want to cardiovert, and you're going to look at where the monitor is saying it's going to apply the joules and make sure that it's not on the T wave. So in that patient that we just saw a minute ago, this one, the advice would be choose a different primary lead. Okay, because right now what it's choosing is this upwards that it's seeing as the R wave, but that's actually into the T wave. So choose a different lead. This would have been a better lead, right? Because here's your QRS, and then you can see that you really have that inverted T. So the monitor should have been able to differentiate that, and it would say, okay, we're not going to apply our synchronized cardioversion during the T wave. I'm going to do it outside of that T wave window. And so the monitor has to be able to differentiate it. Okay, so typically, who's going to respond to cardioversion, right? Almost all reentry dysrhythmias are going to respond. They're not going to sustain, but they're going to respond. So A flutter, AV reentry tach, AV nodal reentry tach, reentry ventricular tachycardia almost always respond to cardioversion. But other types of tachycardias are non-responders, like junctional ectopic tachycardia, atrial tachycardia, multifocal atrial tachycardia, and profound sinus tachycardia. Now, you're not going to cardiovert somebody with sinus tachycardia, but you might not have been able to see that they had a P wave. So what does that mean? Look at the 50 sweep speed first before you make any decisions, okay? Remember, junctional ectopic tachycardia, multifocal atrial tachycardia, ectopic atrial tachycardia, single focus, one place in the atria, and profound sinus tachycardia, not going to respond to cardioversion. So really, 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 really important. And that's why one of the things that we say is start with DC shock. Patients should get better. They don't get better, then they're probably not responsive to cardioversion. So sometimes we say, oh, we're going to cardivert first with 100, and then we're going to cardivert with 200, and then we're just going to defibrillate you. But we're looking at patients who are not going to be cardioversion responders. And if we defibrillate them, they're going to have deterioration. Now, honestly, that's not a terrible thing. If you've got an unstable patient, you're not able to control their rhythm. Sometimes it's okay for them to deteriorate to something you can control. Easier to control VFib, in general, easier to control and resuscitate patients in hospital from VFib than it might be from some of these other dysrhythms that are more extraordinary and that are harder for you to diagnose. Okay, so I'm just going to talk really quickly about when the tachycardia is wide, and then I'm going to end, and I'm going to ask you to join again next week. I hope you will. Unstable tachycardia is part 3, because I really want to focus on Torsades de Pointes, because I think it's so incredibly important. So just reminding you, when we're looking at anything from above the ventricles, you always want to consider the process of bundle branch block. So if possible, at the bedside, we're going to choose a V1 with the brown electrode on the right side of the sternum, 4th intercostal space, and a modified V6, taking your left leg electrode and putting it at the 5th intercostal space, mid-clavicular line. You're going to put V1 up there. You're going to put lead 2 up there, but you're going to remember lead 2 is actually a modified V6 in this version. And what you want to remember is that V1 is going to represent the right side, V6 or the modification is going to represent the left side. And what you expect to see in a normal process, current goes away from the right towards the left. So in V1, the electrical depolarization of the ventricle is primarily downwards as the current goes away. But the current is going towards V6, so that should be primarily up. That's pretty straightforward. Should be down in V1, up in V6, okay? You're always going to check V1 and V6. You have to do that. If you only have one Brown electrode, you're going to do V1 and a modified V6, and very modified actually, by taking your left leg electrode and putting it in the fifth intercostal space, mid-axillary line, and you're going to check that direction. You want to remember the direction should always be to the left. That means the abundance of current should be pointing to the left, which means it should always be upwards in V6. And that means it should always be downward in V1, to the left, always to the left, right? So first of all, your direction can be right, but if it takes too much time, that's a bundle branch block. So if it's greater than 0.12, but it's going to the left, I'm going to consider that's probably a left bundle branch block. If it's going towards the right, that's absolutely the wrong direction. It's going towards the right, which means at the end of ventricular depolarization, it will go away from the left. So what you're going to get is a big R wave in V1 and a deep S wave in V6. So really important. We've had numerous presentations here, and I'm happy to do them again, about bundle branch block, independently doing left bundle and then right bundle and anterior fascicular block. Really, really profoundly important that we actually understand how to look at bundle branch block, because that gives us such a window of opportunity in evaluating our patients. So you can see here in normal V1, the deflection of current is primarily downwards, and that means away from the right. And the current is primarily upwards in V6, meaning towards the left. And I always want to compare those two at the same time. In right bundle branch block, I certainly have deflection that's away as I depolarize the left ventricle, but then that current comes back to the right side, giving me a primary upward, and that is not normal. And when I look at the V6 lead, I see I have primary up, but then I have this big S wave. It's never normal to have a wide S wave. That's completely abnormal. The S comes after the R, and it's wide and broad. This is a right bundle branch block. In left bundle branch block, the current goes away from the right side, so it's all downwards. Well, it's almost primarily all downwards anyway. But now look at how much more time it's taking. So the current is away from the right side towards the left, but taking a lot of time. And the current is coming towards the left side, so in V6, it's upright, but again, taken a lot of time. Now, there are other things to look at that are beyond the capacity of this program. Just to remind you, when you look at an EKG, look at V1, if you're doing it at your bedside, V1 and a modified V6, and actually evaluate, does the current go towards the left and away from the right, meaning downwards in V1 and upwards in V6, and that's primarily downward in V1, primarily upright in V6, and taking less time than 0.12 seconds. That's normal conduction. That's really important because we're going to use that when we evaluate our patients and try to make some comparison. So now if you just take a look again, you have a right bundle branch block, primarily upright in V1, and you're still primarily upright in V6, but you have this wide downward end of depolarization. That's called the wide deep S wave. If you have left bundle branch block, you're going primarily away from the right side, which is normal, but it's taking a lot of time. You're going towards the left side, which is normal, but it's taking a lot of time. Don't make it harder than it has to be. Try not to memorize all that stuff, right rabbit ear and all that stuff. Just say, I'm thinking about the heart. Current should be arising from the sinus node and traveling towards the apex of the heart. So current's always going to the left, and it shouldn't take much time. That's it. It's pretty straightforward. Okay. Now, this is not so straightforward, right? Because I can see a patient here who this is a wide QRS tachycardia. It looks quite regular. So I am a little worried it might be VTach. It's a very rapid rate. It's regular. It's wide. But when I look at V1 and V6, I can see that this is a left bundle branch block pattern. So my first thought is it's SVT with left bundle branch block, and I'm going to focus on the SVT. Now, you know, amiodarone treats VT and SVT, so that's a really great agent. It just may not be so great if there's an accessory pathway, but I'm going to use amiodarone as my first therapy. Okay. And if I have to shock the patient, I'm always going to cardiovert because I don't really know whether it's SVT or VT. Okay. Now, this is with an accessory pathway that's on the right side of the heart. I don't expect any of you, nor would I expect myself, to be able to diagnose that from this simple EKG. But what I'm actually seeing is the current goes away from the right heart and towards the left heart. This also looks like a left bundle branch block, but this is not a bundle branch block. Okay, so it's not SVT with the bundle branch block, and I'm going to be cautious. So let's say we gave that patient amiodarone, they didn't get better. Your doc said, oh, let's give a calcium channel antagonist. We gave a calcium channel antagonist, and now their heart rate has increased 50 beats per minute. Uh-oh, step back. I was treating the wrong thing. I think this is an accessory pathway. I don't need to say, is it right? Is it left? That's not important. Think it's an accessory pathway. Patient got worse when I gave a beta block, when I gave a calcium channel antagonist, or if I gave adenosine, patient's going to get worse. Okay, so that's really, really, really important. This is an atrial fascicular reentry, meaning it's coming from the fascicle of the bundle. Very complex. We're not going to worry about it. And then down there, you're seeing this is actually ventricular tachycardia. Okay, but it kind of looks very much like a left bundle branch block, right? It's rapid, it's regular, it's wide. Current goes away from the right heart and towards the left heart. Can I really differentiate this easily as SVT versus VT? No, I cannot. I cannot. So what's my best bet in any one of these? What's my best bet? Cardioversion. Cardioversion. Choose a primary lead that doesn't interfere with the algorithmic evaluation of the QRS. Make sure that you're not going to fire on the T. Cardioversion is the choice treatment for all of these, not medical therapy, because that can make your patient work. Cardioversion. If they're unstable, cardioversion. Even if they're not unstable, I would tell you. Okay. All right. So always consider the possibility of left bundle branch block. That's easy to do here. We got a nice narrow, nice slow heart rate. And we're saying current goes away from the right and taking a lot of time. Current goes to the left and taking a lot of time. I can validate that with V6 and V5, which are left-sided leads, and leads 1 and AVL, which are left-sided leads. This is a left bundle branch block. Now, one of the really important things, again, beyond the aspects of this talk today, is that repolarization is also altered in bundle branch blocks. So typically in the leads that are facing where the bundle branch block is, you're going to see that you have a sloping downwards of your ST and an inverted T wave, which indeed you see here. Oy, the blocks, the blocks, the blocks. Remember, in left bundle branch block, your current is rapidly distributed to the right heart and then slowly returns to the left. The left ventricle, which is normal, is depolarized last. And that's normal. That's normal. But it's going to take time. The direction is to the left, but it's going to take time. So that timing is a really important thing for us to look at. So again, we kind of remind ourselves of what you look like in V1. It's really wide, broad, taking a lot of time. And in V6, it's wide and broad and taking a lot of time. In right bundle branch block, always remember that completely abnormally, the right ventricle is depolarized last. It's always supposed to be depolarized first because it's thin, narrow, doesn't take much current. But if I'm seeing that current is moving towards the right heart, that's telling me that the probability is this is a right bundle branch block. So what I see is this little tiny R, which is, whoop, the right ventricle depolarized and everything else should go to the left. But I have a return to the right here. This is what people traditionally call right rapid ear, only present in about 10% of patients with right bundle branch block, which is why I don't want you to look for that. I just want you to see that the majority of electrical activation is pointing current towards the right heart. Okay, should never, ever, ever go to the right heart, should always go to the left heart, and it's taking time. And of course, you have repolarization abnormalities. Now we look at SVT with a right bundle branch block. Okay, so we've got an SVT with a right bundle branch block. We have a little R and then we have a second R. But over here in V6, what you're looking at is that broad, deep S wave. So when I look at that, this one, I would immediately say, it doesn't matter how fast it is, this patient has right bundle branch block. 93% of patients who are assumed to have ventricular tachycardia actually have SVT with right bundle branch block. Now, 20 years ago, that was a problem because we separated the treatment for VTAC from supraventricular tachycardia. For VTAC, we used lidocaine, pronestyl, quinidine, or any of those derivatives. Those were all sodium channel antagonists. And for atrial dysrhythmias, we use primarily calcium channel antagonists or adenosine. But now we say, hey, too hard to actually evaluate this at the bedside. So isn't it fantastic that we have a potassium channel antagonist, and that's amiodarone? So with SVT with bundle branch block or VTAC, we're going to use amiodarone as our primary pharmaceutical intervention. But still remember, cardioversion is the safest, particularly if I don't know whether or not the patient has an accessory pathway. I'm going to use cardioversion. Or if I give medication, the patient gets worse, I'm going to use cardioversion, or now I'm going to do defibrillation. Okay, now this one is ventricular tachycardia from the LV, but it looks like a right bundle branch block, except that you don't have a significant upright here. So it's downward in V6. The impulse is forming really from the lateral left ventricle and traveling all the way over to the right ventricle. That's really important. So when you look at that, you say, well, if it was just left, if it was just right bundle branch block, I'd have an upright in V1, but I'd still have a pretty big upright in V6, but I don't have that here. This is VTAC from my left ventricle. So up here, you can see current goes towards the left and towards the right? So it goes towards the right, goes towards the left, but at the termination of that left-sided lead, it goes back to the right. Here, current goes to the right and away from the left. That almost always indicates that it's ventricular tachycardia. Okay, so here's a patient, very nice. It's just nice and it's slow. It's really lovely. And you can see your patient has a little current to the right and then a return of current to the right. This is a right bundle branch block. When I look down here at V6, I see that I have current to the left, but then I have this broad S wave. I should never have an S wave. Even though you always call it QRS, you shouldn't have an S wave. This is a right bundle branch block pattern. And it's great to look at it in somebody who isn't having a tachycardia. So first of all, we take a look at this and we say, oh, look, this is a really wide complex tachycardia. It's really, really fast. And by the way, it's irregular. It's irregular. So right away, I'm going to say, does everything point in the same direction? Or are you twisting up and down? If everything points in the same direction, you're wide and you're irregular, probability is this is not VTAC. Although looking at that, maybe you would never have said that, but this is not VTAC. Look at how irregular this is. Remember, VTAC is almost always regular, except for polymorphic, which means it's not going to all look the same. So here you are, you've got this and you're like, oh, that's VTAC. No, it's not. No, it's not. It's actually pre-excitation atrial fib at very high rates and AV nodal reentry tachycardia. Okay, so for this patient, therapeutic intervention. Oh, look how bad my spelling is. Sorry about that. Pronestal, abutolide, and cardioversion. And if you don't have anything else, you haven't got Pronesto, you need the cardiologist to get it, you're going to cardiovert. You're not going to spend any time on drugs. You're not going to give adenosine to try to differentiate. You're not going to give a beta blocker to try to differentiate. Sometimes docs say, let's give a beta blocker and see if that differentiates. Yeah, no, I'm kind of uncomfortable with that in this situation because I don't really know, does this patient have AV nodal reentry? Typically, patients with AV nodal reentry are going to have much more rapid heart rates. So we just want to think about situationally, we expect to see any supraventricular rhythm to be less than about 220. When you get up to 250, 280, you've got to think that that's a reentry, and that should be behind your mind's eye when you're treating your patients. Okay, so I just want to remind you, tachycardia with hemodynamic instability, just the first thing you're going to try to do is ensure it's not sinus tach, and you're going to cardiovert. Okay, if they're unstable, you're going to cardiovert with or without sedation. Please synchronize. Make sure that because you're so lucky with your device that it shows you where it's going to apply the shock. If that shock is not clearly differentiated from the T wave, then change your primary lead, and then also be prepared, of course, for post-shock bradycardia, hypotension, left ventricular failure. Be ready to do CPR, be ready to give atropine, be ready to give epinephrine. Be prepared. Don't have people running all over trying to find stuff and pulling things out of the cart. The cart should be open. You need to assign somebody. I might need atropine, I might need epi, I might need a bag. Let's get ready. Let's be prepared. Let's not fall apart. Let's not be chaotic. Let's not be chickens with our head cut off. I'm here and I understand rhythms and I understand how to control them. And that sense of calm is a really important thing for us to produce when we're talking about unstable tachydysrhythmias and remembering that sometimes intervention is diagnostic. So We all are going to make mistakes. We're all going to give agents that make our patient worse. It's not a failure of the drug. It's that we didn't treat the right event. So we expand our mind to not just say SVT, because SVT covers a tremendous amount of problems. And what we want to do is give the best therapy for the problem. And we're really lucky in today's world because we have amiodarone and we have cardioversion. And we're going to give adenosine when you have something that we can't differentiate as supraventricular tachycardia. But the more rapid that supraventricular tachycardia is, the more likely is that the patient has an accessory pathway. So adenosine might not be the drug of choice. Beta blockers may not be the drug of choice. Calcium channel blockers may not be the drug of choice. I want to thank you very much for joining today on Wonderful Wednesday for part 2 of unstable tachydysrhythmia. I invite you to join next week when we're going to cover VTach, polymorphic VTach, really not VF because that's pretty straightforward, but torsade de pointe, which is not so straightforward. We're going to think about the management methodology for those patients. But for today, what I want to remind you, 50 sonometer sweep speed if your patient is stable to help you try to discover what the real problem is so that you can treat the actual problem and not just the symptom. And to remember that the more rapid the supraventricular rhythm is, so remember, you're looking at supraventricular rhythms and you're looking for whether it's an abundant branch block pattern. It might be narrow, it might be wide, but the more rapid it is, the more you need to consider that this is a reentry tachycardia. And to remind yourself, doesn't mean you're not going to give adenosine, but that adenosine may make the condition worse. So if the condition gets worse, then the probability is this is a reentry tachycardia, either through the AV junction or through an accessory pathway. And so we're going to remind ourselves that once we've made that decision, we're not going to use beta blocks. We're not going to use calcium channel antagonists. We're not going to do any AV nodal blocking. We're going to slow down fast channels in the AV junction, fast channels in the accessory. And that really does require that we have some type of sodium channel antagonist. And by the way, that requires cardiology. All right, I am going to sign off here. If you have some questions, please email me because they're ringing the phone. They need me to move. And I'm so grateful for you. Thank you for coming today. I really appreciate your commitment to patients and to me. And I'm going to see you next week. So thank you. Hope you learned something new today. I hope that I'll see you again next week. And I'm sorry to say, I'm going to go ahead and sign off because I definitely need to move out of my room. All right, my guys, thank you so much. Mwah. Thank you for everything you do. I'll see you soon.